Dear Pure Urology viewers, good evening, one and all. Today, our topic is ECIRS, endoscopic combined intrarenal surgery. As you all know, last 5 to 10 years, RIRS has come way forward to treat different type of stones in the kidney. At the same time, stones, multiple stones, it is difficult for RIRS to perform. So PCNL is of choice for large stone volume. Additionally, prone PCNL is done in the 90% of the urologists. But if you want to combine RIRS and PCNL, then you have to do supine PCNL. Even though prone split leg position ECIRS can be done, but not well practiced in the world. So supine PCNL again from last 5 years has come into limelight, both for ECIRS as well as per se also. So if you want to combine, it is called endoscopic combined intrarenal surgery. To give good SFR, this technique has become popular. Scaffold as popularized same time from and Dr.Joon have done a lot of research, and they are pioneers in the ECIRS as well as supine PCNL. So today, let us listen from these two important speakers. Before I will share the screen and introduce both the speakers of today, the Professor Dr. Sung Yong Cho. He is a professor, head of Stone Endourology Center at the Seoul National University Hospital, Korea. He is graduate from Seoul National University in Korea as a surgical urologist who specialized in diagnosing and treating urolithiasis, BPH, stricture, and upper tract TCC. He is in charge of the specialized luminal endourology stone center and usability test center in Symmetry SNUH Innovative Medical Technology Research Institute in the SNUH. He is one of the members who are leading stone surgery in Korea and East Asia. He is the Korean representative of the Asian Guidelines of Urolithiasis panels in the 2019 and has successfully fulfilled many educational works and live surgeries in the urology conferences. He has published more than 40 papers. Today, we have another speaker who do combined work, Dr. Joon. He is the chair department of urology at Daegu Fatima Hospital, South Korea, graduated from Kyunpuk National University School of Medicine, South Korea, worked as instructor at Kyunpuk National University Hospital, specialized in endourological stone surgery, BPH and incontinence surgeries, member of Korean Society of Endourology and Robotics. He has published more than 30 papers. With this introduction, I will hand over the program to Professor Sung Chong and Joon. Over to you. Thank you for accepting the invitation. Over to you.
Thank you.
Thank you for inviting us. So start now?
Yes.
Oh, thank you. So today, the talk, Dr. Jo, do you have any comment before this speech?
No, please go ahead. Thank you.
Okay, thank you. So first of all, it's a great honor to invite me to this important webinar speaker. So I know some of you have a lot of case of endoscopic surgeries in India too, but I would like to share my ECIRS cases, so focused on the some considerations the performing the ECRS for the stone surgery. So I make my subject today. So when do I prepare ECIRS rather than a single procedure? Because for the most stone surgery, I do not perform the ECIRS every time. Usually I perform the retrograde surgery or the PCNL. But in some cases, I consider, so whether do I perform combined surgery or not. So I think this would be an interesting topic. For treatment of a complicated urinary calculi, normally I plan what type of surgery would be the best option for my patient. For small and multiple stones, I don't hesitate to choose retrograde surgery first. But for big stone, I consider miniaturized PNL first and RIRS as the next option.
Dr. Kwon, please share the screen first.
Oh,
Yeah, I can see your face. But
oh, sorry. So
yeah, please
I
share.
think it is shared.
Yeah, okay,
I'm
please.
sorry. Okay. Could you see the slide?
Yeah, yeah,
Thank
thank
you.
you.
Thank you. So when should we consider bidirectional combined approach of antegrade and the retrograde access? It may mean the initial bidirectional approach to the target or intraoperative conversion of surgical method. It is important to surgeon and more important to our assistant who have to prepare the surgical equipment and the patient position before doctor's arrival at the operating room. So there are lots we can consider of preparing ECIRS. The patient position may be important. Indications and the patient selection also be another important point. There are lots of devices. So is ECIRS really necessary? Because it needs lots of devices. So how to use laser efficiently? So in the point of doctor's number, so single urologist or assisted single urologist, or if possible, 2 urologists may be better for the performing ECIRS. So how to shorten the operative times is another good point. And during the surgery or decrease the post-operative complication, the intrarenal pressure and temperature may be also good consideration points. So first of all, we can think multiple options for patient position. Easy accessibility to the target, easy conversion of operating method, device and equipment, and the surgeon's preference can all be important parameters to choose the patient position. The anatomy of kidney and the ureter is also important because the anatomy under nephrostopic and the flexible ureteroscopic guidance should be intuitive to the surgeons. Now, this figure is showing different endoscopic view of the different calyxes from plank area in the supine position. The lower pole is normally located higher than the kidney upper pole. Anterior and posterior calyxes are matched to the upper and the lower direction of the nephrostopic inspection. So now let's review several stone cases and think of the things to consider together. This is the first case. 61-year-old male person visited our hospital. So he complains instantly found the right renal stone from the private clinic. He complains no pain, no other symptoms. Urine test reveals minimal microscopic hematuria, but there are no pyuria, no bacteriuria. He had the normal renal function, and he had also the hypercholesterolemia, but other medical history is absent. This is preoperative CT scan. In the right kidney upper pole, maybe the stone is located in the middle of a kidney parenchyma, not the collecting system, is about 14 millimeter. And there are also small stone fragment in the, maybe I think it's upper calyx. In the coronal view, you can verify the stone location is just the upper lateral portion of the right upper calyxes. In the excretory phase, the contrast material was filled in the small diverticular cavity compared to the excretory phase. And the washout is also slowly conducted. So it means that I think there are very little opening for the diverticular neck. So the washout is very slowly done.
John, your
You have
voice
any
is not coming.
Sorry? Do you hear
Voice
me?
is not coming.
I can see the
Unmute.
slide. No, just
In this slide,
Sung, can you speak?
yes, I can speak and I can hear Dr. Kwon's slides and sounds. So I think no, there's no problem for me.
Hello.
Dr. Chandra Mohan, do you hear me?
Your voice is not coming, June.
Mhm.
Is there some traffic problem?
Yeah, now it is coming.
Oh, good. Very clearly, I can hear. Do you hear me?
Yeah.
Thank you.
Yeah,
So I restarted the CT scan.
Yes.
Okay,
Yes.
thank you. Yeah, I will speak slow. So this is pre-operative CT scan. Do you catch it?
Yeah.
The
Yes.
stone. Yeah, we can find the stone is upper renal parenchyma. Maybe the stone located in the outside of renal calyx. So we consider it maybe the diverticular stone. And there are another small stone in the upper calyx. In the coronal view, stone is clearly seen in the upper lateral portion of renal upper calyx of right kidney. In the excretory phase, the contrast material was filled very slowly in the small diverticular cavity. You can compare this here and here. And the contrast material was washed out very, very slowly. I think it means that there are very small opening of diverticular neck. Can I pass the next slide?
Yes.
Thank you. So next step, so we plan antegrade assessment first, preoperatively, because in the past, I had an experience of a failed retrograde approach in a case where the diverticular opening was completely occluded. So I want to the pre-keeping of a PCN catheter for using of intraoperative the HAP. In the antegrade fluoroscope imaging, there are multiple small stones were observed in the small diverticular cavity. Diverticular opening was predicted to be very small when seeing the very slow filling rate of contrast. Unluckily, guide wire failed to pass through the diverticular neck to downward. So
Yes.
if the space is enough too large, I might roll up the guide wire in the diverticular space, and I will try the PCNL first, but the space you see is very small. So guide wire roll up is very difficult case. So in that situation, so during the track treatment, I can lose the guide wire. It's very risky. So
Yes.
I decided the retrograde approach first. there are also some problems. So you see in the UPJ area, there are severe kinking. The ureter is nearly 180-degree tortuous. There are no definite structure, but there are some flap. So it's difficult to pass, severe kinking. And I can find in the upper calyx, there are very small hole, but in the initial view, I cannot find any. So I use the indigo carmine administration into the PCN catheter. So and then I can find the leakage from the very, very small opening. So I confirm that this may be the diverticular opening. So using the laser, I inside the opening and widen the diverticular neck.
Okay.
Like this. So there are lots of small stones, very round shape, as you know. Without breaking stone, because stone is small, I think, I would like to remove itself with the basket. But because of the UPJ thinking, so always I try to remove the stone, so it was entrapped in the area of UPJ. So I think next step, I would like to the pop dusting technique, because I need stones more smaller to passing the UPJ area, but stone was too hard. I using the energy 2 joule and the frequency as a 30 to 40, but the breaking is not easy. So the next step, I changed my plan to using the PCN track and performing the simultaneous PNL.
Okay.
Okay, and this is the picture. I'm sorry, I do not gain the PNL movie clip, but you see, it is already very small stone, and just making the track is enough to removing the remnant small fragments. So the procedure was very easily performed when I making the track. There are no remaining stone at the post-operative imaging. Can I pass the next case?
Yes.
Okay, thank you. The second case, the
In
43.
the previous case, it might have been very.
Sorry.
Okay.
Okay. Yeah. Next case. So this is second case. So man with 43 years old man who complains penis gross hematuria. In the urine test, there are hematuria, pyuria, but no bacteria growth in urine culture. He had normal renal function and no other medical history. This is preoperative CT scan. In the corona view, there are in the upper ureter, left kidney, there are 2 big ureter stones, you can see, and some small 2 pieces of small lower calyxal lanar stone.
Yes.
Okay. Yeah, big ureter stone and very small renal stone. Usually, I think in these cases, I think the RIRS is enough to remove the ureter stone and the lanar stone. But for my past experience, in the CT scan, the lower calyxal and infundibulum and the lanar pelvis, the angle is very acute. So I worried about it. When I approaching the retrograde flexible scope, I cannot access the bottom of the lower calyx. So preoperatively, I keep the PCN catheter for preparing the antegrade access. In the AGP film, the lower calyx angle and the renal upper ureter is nearly parallel. So it means that very steep angle. And in the upper ureter stone, I can easily remove and breaking the stone. Then I try to approach the lower calyx or bottom, but as I worried, it is very difficult.
Yes.
So using the PCN tract, I get the PCN tract and performing the miniaturized PNL and easily remove the lower calyx or stone. And this is third case. So 60-year-old man with gross hematuria. So he also revealed the microscopic hematuria, pyuria, but in culture, there are no bacteriuria. Also has normal renal function and no medical past history. The preoperative CT scan. Yeah, stone was very lots of branching, particularly in the middle calyx and the lower calyx. When you
Yes.
see the middle calyx, the branching is at least two or three side, and in the lower calyx, the branching is anteriorly and posteriorly. So usually in such a case, when I performing PNL, if there are some spaces to approaching the upper pole, so upper pole approach may be helpful to because the lower calyx is branching. But in this patient, in this patient, upper pole dilatation is a little nearly scanty, and the stone is located somewhat anteriorly. So the approaching the upper calyx is maybe, I think, is difficult. So so what I want to say is this calyx anatomy and the stone shape is very complicated. So single session of PNL is not enough to remove all of the stone. So staged operation may be another good choice for this patient. But patient is somewhat young, so just a 60-year-old. He want to remove just one session. So there are some option for removing the one session procedure. So option one could be the multi-track PNL. Luckily I have a miniaturized PNL set. I can use there are little risk to the performing the multi-track PNL. And the second option will be ECIRS. So mainly PNL to remove reducing the stone burden, and the RIRS for remaining stone fragment will be helpful to nearly completely remove the stone. Sorry, is there any problem to hear?
No, yes, please continue. Sorry.
Okay, thank you. And this is a preoperative antegrade fluoroscopic picture. So guide wire are passed to the blood level through the kidney. This is for PNL, the PCNL tract was lodging to the lower calyx. And luckily, nearly most of the stone burden could be removed by PCNL, but there are remaining stone fragments floating around the renal calyxes. And I performing planned retrograde surgery too. The video is not good because there are already lots of stone burden are removed. So one of the mistake I usually do is I think I'm finishing the stone surgery and most of stone are removed when I think, but there are still stone fragment, usually near the tract. So always I have the same problem. So in this person, I try to find beneath the PCNL sheath, there are still floating remained stone. Yeah, I can find this. There are several stone fragments, and using the basket, I remove them.
This is difficult.
Sorry, the video is not good for the.
No, this is difficult case.
Right, just we have to always check the presence of remnant stones below the percutaneous trap while we retrieve the trap, right?
The movement of the flexible scopes are difficult below the ampla sheath.
Yes.
Very nicely demonstrated.
Yeah, yeah. Please keep going, Dr. Kwon.
Yeah, thank you. And like this, I think I removed all of the stone when I finishing the surgery, but unluckily, when I taking the post-operative CT, there are some small fragments still remain in the kidney. So it's not good result. It's not good case. But there are not many video records for the ECIRS. So I just prepare this case. And this is last slide. So there are lots of available cases for ECIRS. So personally, I think my personal preference for ECIRS is for the complex stone, and the calyxal anatomy may also be very complicated. So in these cases, we can predict no good result with a single procedure like RIRS or PCNL. So ECIRS can be a good candidate for the removing the most of the stone burden. And when predicting an unfavorable urethral factors, though RIRS is planned. So in these cases, as I demonstrated you, so during the surgery, you can convert the surgical method from the RIRS to the PNL. So the position is important. And the last, antegrade procedure is planned, but guide wire passage is unsuccessfully predicted without retrograde help. Particularly in the case of impacted stone with Stagon calculi. So sometimes the guide wire is not easily passed to the downward of to the bladder. So in that cases, using the retrograde endoscope and making some breaking the stone and get some space for the passing the guide wire, and then you can easily get the PCNL tract. It is a good tip. Thank you for attention. Yeah.
Thank you. Sung?
Yeah, just I think that the first case for diverticular stone, I feel the consecutive approach is better than simultaneous ECIRS because we can choose one of the options of antegrade and retrograde approaches. And Dr. Kwon planned the antegrade first, but basically just it was not a good case. So retrograde approach then was the just good choice for the diverticular stone removal. So
Sung,
I think
I want to ask you one question.
Yeah, okay.
In the first case, whenever you do RIRS, if you find small stones, round stones, smooth stones, they are very difficult to lace. What are your tips? You cannot use basket 100 times.
Right.
So many stones will be there in calyces. You will be seeing them, but you cannot powder them. Do you think that they will come out naturally, or you should go for small mini perk and remove them so that you have happiness of on table 100% SFR? What is your opinion? Multiple secondary stones in
yes. We can see many cobblestone like features. Right? So very small round type. Yeah, so basically for me, just I prefer RIRS to PCNL. Of course, we can see many basketing can be necessary, but basically I normally choose a pap testing. Of course, there must be a very high risk of postoperative infection, but basically, if diverticular stone, diverticular space is located in the upper pole callus, then just we have to be careful about the bleeding chance while we make the percutaneous tract to the diverticular space. So just I normally check the retrograde pyelography first, whether there is any just diverticular neck or not, and I will try the RIRS first. But there must be many discussions about that, right?
Similarly, even in PCNL, a large secondary stones very difficult to break with pneumatic lithotripter.
Yes.
Difficult to break with pneumatic lithotripter. They will be
Right.
escaping. And doing with laser is taxing. Doing with
Mhm.
quite time taking. Ideally, something like trilogy or suction with ultrasonic is better. So what do you comment? Large secondary stones, cystine stones, if they are there like that, smooth large stones. What are the tips?
Yeah, for that case, for example, yeah, such as cystine stone or just very high risk of recurrent stones, then complete removal is very important. So at that time, maybe I will consider percutaneous approach, but maybe Dr. Kwon has another opinion, right? Just what do you think of this case?
No, I agree with Dr. Chandra Mohan's opinion. This is very good tip. So ultrasonic suction is breaking the stone, simultaneously suction the stone, and because of the negative pressure, so it will be helpful to removing the stone. So it's also my preferred method.
And a large access sheath also will help in such cases.
Right.
Better not to use small tracts, little bigger tracts to remove intact, also useful.
But for the mini PNL, I usually using the laser. So in that case is rise burden is not adequate for the mini PNL. But
Chandra, do you mean the large access sheaths with RIRS for
no.
frequent
Large ample sheath for removing of the large round stones in PCNL. What exactly I mean? PCNL. So that breaking part will be less.
Right. And basically, if that vertical neck is very narrow and small, then we don't need to worry about any passage of the stones into the renal collecting system. And basically, suction can facilitate stone retrieval. But basically, I don't think it take much time to remove all the stones without any suction. If we don't have any suction, right? So we can do that, but as you already told us, then the suction can facilitate stone removal regarding the time.
Yes.
And I think the second case is is one of the best cases for simultaneous ECIRS, right? The ureter stones and lower pole stones, but the infundibular pelvic angle is so accurate, so you can do that simultaneously. But for the cases the first one and the third case the case, I think the consecutive approach can be better than just simultaneous ECIRS. So many people are confused at the simultaneous concept and consecutive concept about combined approach. So I wanted to tell you the second case can be the best case for simultaneous concept of a combined approach.
In case of ureteric stones, do you like to push in toto and then remove through the nephrostomy tract than manipulating in the ureter? Because ureter is sensitive. If you push two stones into pelvis, come from the lower pole calyceal stone region, finish all the three through the nephrostomy, and just keep the flexible scope in the upper ureter so that migration of the stone will not be there down, and happily you finish all the 3 stones.
Sometimes I
What do you think
also, oh, sorry.
Yeah,
Sometimes-
What do you think of the Dr. Kwon?
Yeah, in this cases, there are the alternative method. So if I preoperatively decide to this case to performing the PNL first, I would push the ureter stone to the renal pelvis as you told, and performing the PNL single
Mhm.
procedure. But before this surgery, I planned. I'd like to finish this surgery with the RRS just a single session, but I worried the remained stone, and if I worried cannot approaching the lower calyx, so this procedure is converted to like the ECIRS.
Yeah.
If I already made my decision preoperatively, the PNL, I may put the ureter stone to the renal pelvis. So that's good choice. Yeah.
If you want to puncture in multiple stones in the kidney in supine PCNL, like in prone PCNL, we do supracostal puncture to reach most of the stones into the upper ureter, inferior calyx. What is your opinion? Which is the ideal puncture? Leave ECIRS, ideal puncture for supine PCNL to get maximum out.
So it is best.
Because
answered by
because the
Dr.
concept
Joon.
of upper pole puncture in the prone position can be quite similar to that of lower pole puncture in supine position,
Yes.
because regarding the direction, right? But for this case, lower pole stones with very acute infundibular pelvic angle and the upper ureter stones, lower pole approach cannot be so good for approaching to the upper ureter stones. But maybe I will try the mid pole puncture if it is okay to approach the lower pole stone. But basically, I feel this I will make the lower pole puncture and I'll push the ureter stones into the upper pole calyx. And if I place the ureter catheter in the upper pole calyx and push it with normal cell line, then maybe I can remove all the stones together with the single lower pole percutaneous trap, because there is no mid pole stone, right? So maybe just a single just trap in the lower pole calyx can be available. I hope, maybe I guess, but just I think this kind of big upper ureter stones, there can be quite just impacted ones, and I still worry there must be any just stricture postoperatively, and I need to check the upper ureter status about to evaluate the risk of ureter stricture in the near future. So maybe if it is okay, then I'll make the lower pole single cutaneous track, and I'll try the RIRS, and then just at the end of the percutaneous procedure. But if the stones can be impacted, and we cannot make any we cannot see the retrograde pyelography because it can be quite completely obstructed. So ultrasonic puncture is necessary. Then we should prepare the ultrasonographic machine preoperatively. So that would be this one point that I want to tell you.
Yeah, that's very important. How often, Sung, Professor Sung, you use ultrasound in your theater for puncture of the PCS? How
I
often?
always prepare it.
Always, yeah.
Yeah, so just because there's, of course, the complete obstruction case is mandatory for your use of ultrasonography,
but otherwise,
yeah,
also,
okay.
Otherwise also you use routinely ultrasound to assess the system?
No, for me, I mostly I use the fluoroscopic guidance. So the patient position may be nearly the most case the prone. So I'm not used to the supine position PCN puncture. So Dr. Joe are very used to the supine and the supine position PCN puncture. So in that case, ultrasonography is very helpful. So this is because I preoperatively PCN catheter keep before the surgery. So when I making my patient position to supine, so I have some difficulties to puncture. So
Yeah.
Don't misunderstand me because I started my percutaneous puncture under fluoroscopic guidance
good.
in my initial period. So I know how I do it.
he's the
with,
expert.
fluoroscopy only.
To puncture
Yeah, you are expert in
Good.
fluoroscopy too. You are expert.
Yeah, sure. Yeah,
Right.
it works.
Last,
It works.
last couple of questions.
Mhm.
In supine PCNL, if you are not using ultrasound, most of the times, C-arm guided puncture will be anterior calyx. Do you agree?
So for me, I already kept the PCN catheter in prone position and making the patient position to the supine, and then I making the tract dilatation. So not always the anterior puncture, I think.
Yes, I always worry about the bowel injury. So I always try to approach in the quite posterior side of the
Posterior
patient.
side.
So
Posterior
normally I touch the posterior side of the kidneys. So I don't think the anterior approach can be available only. So just posterior approach can be quite, yeah, just feasible, and I think can be
Got the
easy.
point.
Yeah.
So be on the safer side. You will be more posterior to the posterior axillary line. So chances of posterior calyx is high. That's what you mean to say.
Yeah, just modify supine position, and just direction is like this. So going upward, and we can touch the posterior side of the kidney. So you don't need to worry about the percutaneous tract and the anterior calyx.
Yeah. But when you are doing a flexible ureteroscopy and nephroscopy, when both come together, the other light will obscure you. You have to switch off one light to inspect the surroundings. Otherwise, you will not see anything. If both lights are there, you should know whether you wanted to search with flexible scope or you want to search with nephroscope. I hope you are understanding. In the surrounding calyces, one light should be off. What do you say?
That's a very good point. So I cannot show you my video clip, but there you can see because
Yes.
there are two lights, the too bright, so I cannot see it.
Okay.
So in that case, your tip is very good. So one endoscope, the light should be turned down, or the scope maybe go back. You understand?
Yes.
So making the light dimmer, so it
Yeah,
is
right. We need
easy
to get
working.
some space, right?
My last question. After doing PNL mini perc, if you have residual stones like in third case, how early you can go safely so that leak of the fluid is not there? When will the tract completely close so that intrarenal pressure will not open the PCN tract? For the small residual stones, when can RIRS be done?
Sorry, I cannot understand well. So please, Dr. Joon.
After doing mini perc, you have residual stones. After how many weeks you will do RIRS?
After the PNL.
Yeah, right. So
I have an experience.
When did you plan?
3 weeks after the PNL. So this is Dr. Joe's advice. So I also curious about when the tract is healed. So when I'm performing the 3 weeks after PNL with the intrarenal surgery, I can find the puncture site was already closed completely. 3 weeks.
3 weeks.
Yeah. But 2 weeks, maybe possible. I don't know.
Yeah, it can be feasible. Yeah, I normally plan. Yeah, right. Yeah, just RIRS, because we can see whether the percutaneous tract is obscured or not while we do the RIRS. So we can check it. So you can just place the double J catheter, and you can just determine, or we can see how long we place the double J catheter after ECIRS. So I don't think this it does matter to me.
Dr. Sung, what is the largest size of nephrostomy tract recently you have used for large stone volume?
Yeah, only just I think a 20 or something. No more standard 30 French. So and basically, I feel just recently during the last several years, actually, just frankly speaking, I am using only 18 French and 16.5 French percutaneous tract. But I will use multi-tract because when I use the multiple tracts, then the no intrarenal pressure can be seen during the PCNL. And basically for large stones, for example, for stagnant stones, there must be the high risk of infectious stones, right? Multiple tracts cannot increase the intrarenal pressure at all. So just I feel there's no backflow into the kidney, right? So just I feel the basically I'll use multiple tracts, but 18 French can be better. Of course, the 20 French, 22, 24 can be better for taking the times of operative time, but just I could see always the bleeding in the percutaneous tract, so I want a smaller size, but I will use multiple tracts.
Extension of this question, a lot of the world is moving towards the laser for lithotripsy, even for large stones, for large stones, with especially small tracts. Do you agree it will stay for a long time? Laser?
Basically, 550 we can use. Of course, if you use the laser fiber, then suction can be just another matter anyway. But long operative time, nobody likes it or long operative time. But basically, my preference is 550 laser fiber, and just I'll speed up with some surgical techniques. So
do you use TFL, Joon? Joon, are you using TFL?
Sorry, using what?
No, TFL is not yet registered in Korea.
Thulium fiber in Korea.
Yeah, not yet registered in Korea.
Fiber. No.
But basically, we can see the quite standstill stones while we use TFL because there is no retropulsion, right? So basically, I don't. Until now, I won't use TFL for PCNL.
Yeah. So
I feel the home laser can be better.
Thank you very much. It's a short, cute, very good discussion about the ECIRS. I know Professor Sung is the very experienced professor in the world. In fact, a renowned person for the supine PCL and RIRS. Dr. Joon, you have selected ideal case, middle case, and two borderline cases also, clearly showing there is variability. In only certain cases, ECIRS is useful, not always necessary. Most of the times, PCNL will do the job or RIRS will do the job. You have to be choosy where you have to combine, in which case 2 surgeons, 2 monitors, little bit of cumbersomeness will be there. You are correct. Out of 3 cases, the middle case is ideal case for RIRS, and you have conveyed the message also very clearly. I thank once again both the speakers for such a wonderful show.
Thanks so much.
Thank you.
It's a
Thank you
great
so
time.
much.
Yeah.